Hi everyone, my name is Salaar, and today I'll be talking about our project titled Promoting Engagement in Remote Patient Monitoring Using Asynchronous Messaging. Technological advancements in wearable and smart devices have brought lots of medical capabilities into the hands of the consumer. This has introduced a new paradigm of how healthcare can be delivered, called remote patient monitoring. In remote patient monitoring, patients use health devices to upload their data, and their doctors can monitor that data and escalate care when needed. Remote patient monitoring has a number of benefits, including being a real-time system. So when patients start getting sick, their doctor can intervene in real time and get them help promptly. Second, these systems utilize objective data from devices, which avoids subjective biases. Next, remote patient monitoring optimizes in-person hospital visits by avoiding false positives, meaning preventing patients from coming to the hospital when it's not needed, as well as false negatives, meaning having patients come in when they do need help. And lastly, a benefit of remote patient monitoring is that it provides patients peace of mind that a doctor is monitoring their health and that they are on the track to recovery. At the start of the COVID-19 pandemic, we built a remote patient monitoring platform to reduce the burden on the healthcare system and to provide patients with peace of mind when dealing with this unknown disease. We launched the application in April of 2020 and ran until May of 2022. When patients tested positive for COVID-19, but they were feeling well enough to go home, we would equip them with an oximeter and a thermometer and ask them to use the mobile app. This will let them communicate their systems and measurements to their doctor while they recovered. On the other end of the system, medical doctors use the application to monitor patients, and in cases where patients' health deteriorated, recommend they visit a hospital for increased care. This screenshot shows the mobile application where patients could select what symptoms they had and indicate whether the symptom was new, improving, getting worse, or staying the same. This next screenshot shows the page where patients could submit the readings from their medical devices using a slider input. And these next two screenshots show the messaging feature. This messaging feature was designed to prevent it from overburdening the clinicians. We did this by splitting the screens into two different interfaces, where on one, patients could send a single self-contained message, and on the other, patients could view all the messages they received. We also made it clear to patients that this was not a replacement for 911, and they would only receive a reply if deemed necessary by the doctors. This was the clinician-facing dashboard, where clinicians could monitor their patients. On the left is the view for a single patient, where clinicians could see the patient details, and on the right we can see a graphical representation of all of the uploaded data, as well as a chart where we could see that same data. Beside the patient details section, clinicians could leave notes which they could also send to the patients. This study ran for 19 months, during which we had 4 hospitals use the system, 18 clinicians, and 422 patients. However, of those 422 patients, only 359 actually logged in and uploaded data. On average, patients were enrolled for 7 days. In this project, we focused on the messaging feature and analyzed its effect on 3 stakeholders in the system: the patients, the clinicians, and researchers. To do this, we conducted a quantitative analysis as well as a qualitative analysis. In our quantitative analysis, we looked at the messaging behavior of both patients and clinicians. First, we analyzed the response time of both of our users. We found that roughly 40% of clinicians replied to messages within 5 hours, whereas 50% of patients replied within that same time. And we also saw that the messaging usage had 2 peaks throughout the day, once in the morning and once in the evening. We also observed that patients' peaks were delayed by 1 to 2 hours compared to the clinician peaks. Next, we conducted a thematic analysis of the messaging content of the messages. We used live coding of the messages, which we extracted into themes and then categorized all the messages according to these themes. We saw that clinicians sent messages for 7 different reasons, with the main ones being to request more data be uploaded, to provide information about study logistics, and to conduct general wellness checks with patients. Patients, on the other hand, sent messages most often to provide unprompted health updates, ask study-related questions, and ask health-related questions. However, while categorizing the data, we observed that there were a few categorizations that provided symptoms and device measurement, corrections, or additional data inside the content, meaning using the data from the messaging, we could augment our health dataset with additional details. In our machine learning-based analysis, we attempt to see if this augmentation has a significant effect. To do this, we developed a machine learning model to predict whether a patient would be hospitalized using demographic information, symptoms, and device data. We trained 2 identical models with identical data splits and identical parameters. The only difference was that one model was trained using the originally collected dataset, and one model was trained using the augmented dataset obtained through the messaging feature. After training each model 100 times and evaluating the ROC AUC score, we saw that the model lift obtained was significant. And although the absolute score isn't high enough where it makes sense to use this model in a real-world medical environment, what it does show is that we were able to improve the quality of the data set by incorporating the knowledge from the messaging feature. To finish, I would like to discuss some of the key takeaways that we learned from the study. First, to ensure patient engagement, data collection should have minimal complexity, and by being readily interpretable, doctors will be able to make clinically relevant decisions. Additionally, front-end designers should ensure that all stakeholders benefit from the collected data. We also saw that including a messaging feature is crucial for engagement, but design considerations should be made based on the needs of all users. And the asynchronous style that we used was useful for making small inquiries and doing routine check-ins. And lastly, ensure that patients understand the functionality and limitations of the messaging feature. I would like to thank you for listening, and please feel free to contact me if you have any questions. Thank you.